Hi, I'm Dr. Stephen Dean. I'm a vascular medicine specialist with The Ohio State University. And I'm going to talk to you today about the increasingly visible topic of phlebolymphodema. And I want to address four specific reasons why you should care about phlebolymphodema. Reason number one, understanding the pathophysiology of phlebolymphodema provides valuable insight into updated concepts in lymphatic failure, such as societal vascular guideline recommendations or recognitions such as this, that lymphatic failure is responsible for all forms of peripheral edema. You may be saying, what? That's a novel concept. And therefore, the edema associated with chronic venous insufficiency actually represents secondary lymphedema. So by the time you have a patient with chronic venous insufficiency and has CEAP class C3 or above, that is edema with some form of skin changes, by definition, that patient has chronic venous insufficiency. And more importantly, the venous edema represents secondary lymphedema, also known as phlebolymphodema. Now, let's review the purest definition of lymphedema. That would be the accumulation of protein-rich fluid in the interstitium, which causes chronic inflammation and reactive fibrosis of the affected tissues. Now, I draw your attention to the illustration on the left-hand side of the screen. We have a patient with early C3 disease here. Varicose veins, a little bit of swelling, no skin changes. A purist may say that there's not protein-rich fluid, there's no inflammation, no reactive fibrosis, so does that patient really have lymphedema? So it becomes a semantic controversy in these early C3s. However, if you have a patient with chronic venous insufficiency that's been complicated by lipodermatosclerosis, atrophy blanche scarring, or venous stasis ulcer, there should be no equivocation that these patients meet the definition of a protein-rich, chronically inflamed reactive fibrotic environment consistent with lymphedema. Reason number two why you should care about phlebolymphodema. It's clearly the most common cause of lower extremity lymphedema. In fact, if you look at data from the European Society of Vascular Surgery, this is contemporary data, and others have also recognized that chronic venous insufficiency, that C3 disease or above, affects about 5% of the population. So if you do the math, roughly 325 million people in the United States, that's 16 million out there that have secondary lymphedema from chronic venous insufficiency. And you compare that with cancer, where there's only about 1.5 to 2 million patients out there with secondary lymphedema for cancer. So this it's not infrequent that you read comments such as these. Here's eMedicine 2018. In the industrialized world, the most common causes of secondary lymphedema are malignancy and its treatment. But as you can see from data I just showed you, that the scales are clearly weighted in favor of phlebolymphodema being the dominant cause of lower extremity, secondary, or even primary lymphedema in Western countries. It's about 6 times more common than cancer. And then in fact, data that's been submitted for publication from my institution, the Ohio State University Medical Center, we looked at data from our oncology-affiliated lymphedema center on 440 patients that were referred in for complex decongestive lymphatic therapy. And of these 440 patients, the majority had chronic venous insufficiency. Cancer was actually number 2. Third reason why you should care about phlebolymphodema. It has associated characteristic and diagnostic clinical manifestations as seen here. 3 textbook representations of clinically classic phlebolymphodema. It's specifically showing a combination of chronic venous stasis dermatitis with associated foot swelling. That's classic lymphedema. I'll draw your attention to the photograph in the middle of the screen, and on the right-hand side of the screen, that inverted champagne bottle appearance is consistent with chronic lipodermatosclerosis, clinically classic phlebolymphodema. But it's critically important that you recognize that foot and toe swelling is not required to make a diagnosis of lower extremity phlebolymphodema, as evidenced by this patient here on the right-hand side who has rather advanced venolymphatic hypertension, but yet no obvious foot swelling. And finally, the fourth reason you should care about phlebolymphodema is it has associated characteristic clinical ramifications that are based upon this immunocompromised district. I encourage you to look at this reference sometime. Phlebolymphodema, a disregarded, often overlooked cause of an immunocompromised district or locality. And these examples of immunity-related problems that occur in a phlebolymphedema district include reduced immune response and even an exaggerated immune response. Now, recurrent skin infections, I suspect most clinicians are familiar with the predisposition to cellulitis that patients with phlebolymphedema have. However, a lot of times, and often overlooked, is the predisposition to recurrent and recalcitrant fungal infections, recalcitrant tinea pedis, often attributed to large toes in a moist environment. Just as likely it's occurring because of the associated sectorial immune deficiency. Onychomycosis, very difficult to treat, also occurring because of this immunocompromised district. And this immunocompromised district also predisposes the phlebolymphedema patient to developing skin cancers, such as these 2 cases of squamous cell carcinoma, and even deadly lymphangiosarcoma, all occurring because of this sectorial immune dysregulated district. Finally, a frequent and often underappreciated cause or disregarded cause of this immunodysregulated district would be the associated allergic contact dermatitis that can complicate phlebolymphedema. And here's a great example. So you have a patient that has a dry, relatively stable chronic eczematous dermatitis. You apply an over-the-counter cream, and it converts that dry eczematous stasis dermatitis to weeping eczematous dermatitis. This is because of this exaggerated, paradoxical increase in immune mechanisms that underlie phlebolymphedema. Same thing can happen with a medically prescribed steroid cream. A lot of times the clinicians will think they're going to get better. Same thing happens. An unusual manifestation, this paradoxical exaggerated immune response occurring in a phlebolymphedema immunocompromised or immunodysregulated district. So let's wrap it up on the 4 reasons why you should care about phlebolymphedema. Reason number 1, understanding that its pathophysiology provides valuable insight into updated concepts in lymphatic failure, specifically all edema, or especially the venous lymphedema of chronic venous insufficiency represents secondary lymphedema or phlebolymphedema. Number 2, it's clearly the most common cause of lower extremity lymphedema. It's not cancer and its associated therapeutics. Number 3, it's associated with characteristic and diagnostic clinical manifestations, but don't forget you don't have to have foot swelling to make a diagnosis of phlebolymphedema. And number 4, it's associated with characteristic clinical ramifications that include not only a predisposition to infection, but skin cancers, and we just talked about the allergic contact dermatitis that can complicate phlebolymphedema. And thank you for your attention.